So today with us we have eminent faculty from North Malabar who have immense experience uh, in the field of retina and cataract surgery. So my first talk is by Dr. Laila Mohan. Madam is the head of Academy Contrast Eye Hospital, head pediatric ophthalmology and strabismus, and the chief operating anterior segment surgeon at Contrast Eye Hospital. She will be giving us a talk on strategies for phacoemulsification in vitrectomized eyes.
Thank you, KSOS and Dr. Divya for giving me this wonderful opportunity about cataract and vitrectomized eyes. Nowadays, we all know that combined surgery has taken over many of the issues in where there is retina posterior segment problem with cataract. So cataract formation or progression after 20 gauge pars plana vitrectomy can go up to 80% in 24 months, and use of small gauge vitrector leads to lower cataract formation, whether due to lower amount of BSS use, lower fluid flow, or shorter surgical time, we don't know yet. Early cases present with PSCC in younger patients, and later nuclear sclerosis, either onset or progression in older patients. And if it rapidly progresses, cataract within 4 months formation is there, we have to, even after Avastin injection, we have to suspect trauma to posterior capsule. So what is so challenging about surgery in vitrectomized eyes? There is a high rate of intra and postoperative complications due to lack of posterior vitreous support, which makes rhexis difficult. Poor pupillary dilatation and posterior synechia may be there. Occult zonular instability, which you may not recognize during clinical examination, or PCR may have been there. Fluctuations of AC common, which is common due to a collapsible globe with no vitreous support. And all these make all steps of echo difficult, and perioperative problems of iris damage, choroidal hemorrhage, all have been reported in about 13%. And therefore, planning of surgery from counseling, biometry, incision configuration, IOL design, and type of anesthesia is important. And counseling before surgery is very important to discuss with the patient the expectations of visual outcome. Better to decide surgery early for posterior pole visualization later, and also to avoid difficulties in advanced cataract. Visual prognosis should be assessed and discussed with the patient, whether it was due to a surgery was for an RD with macular involvement, PDR with macular edema, history of ocular trauma or high myopia. All of them can compromise vision due to macular problem. And whether defective vision is due to retinal pathology or cataract formation, also we cannot distinguish between the two. Metamorphopsia or central scotoma, which the patient has before surgery due to macular disease, can persist for after cataract surgery. All these have to be discussed with the patient. And use of dispersive viscoelastic, CTR, whenever necessary, and type of IOL should be discussed with the patient, and standby IOL should be there. Preoperative assessment is important. Pupillary dilatation may be poor in uveitic and diabetic cases, and phacodonosis, posterior capsular irregularities and outpouching. Sometimes you may see a track, emulsified silicone oil, or even large bubbles. Large bubbles may point to a integrity of zonules may not be there. It may be affected, and fundus OCT can be done if it is visible, if the media is okay. And in macular edema, sometimes intravitreal injection before surgery or during surgery may be needed. And B-scan if there is no view to rule out vitreous hemorrhage or retinal detachment, where combined surgery may be better. Plan for topical or subtenon anesthesia, especially when there is myopia. Better not to use retrobulbar, peribulbar. So IOL power calculation is also critical in these cases. Optical biometry gives more accurate measurements, and advantage of IOL Master 700 in fixation, especially in high myopes with staphyloma, because the OCT imaging is there. And Barrett's Universal 2 or Haigis gives consistent results. The effective lens position may be deeper than usual in vitrectomized eye, so we may have to add a 0.5 diopter. In silicone filled eye, following retinal detachment, An anterior shift of the lens may underestimate the axial length and give a myopic shift also. This IOL power calculation by optical biometry can be directly read in a silicone oil chamber, and so it makes easier calculation. But when there is a dense cataract, immersion ultrasound is preferred. If silicone oil is used, a correction factor of dampening for dampening the sound waves from 980 to the speed reduces to 980 from 1532, and the erroneously long axial length may be obtained. So a correcting factor of 0.64 when we use 1000 centistrokes of silicone oil should be there. So incision of the is directed towards the center of the anterior chamber, which makes maneuverability easier, and scleral rigidity is low, so a small side port avoiding leakage, especially when there's an intumescent cataract with dispersive viscoelastic, is useful, which keeps the chamber well formed, and don't deepen the chamber too much because the rexus can go large. And use a microrexus forceps, which makes the procedures easier. So, nuclear sclerosis is the most commonly presenting cataract. When pushing trypan blue, see that too much blue doesn't jeopardize the red glow. There may be posterior synechiae which may have to be separated with a spatula, and there is subthrust due to silicone oil. So, do not overfill. Hydrodissection should be very gentle. Sorry. If you are not gentle enough, you may the rexus may give way, as you see in this picture. There is a, it's not very aggressive, but then if it is more, the rexus gives way. So to prevent this, it is better to dip the posterior lip of the incision so that some amount of viscoelastics is let out. And this is a very common issue, lens iris diaphragm retropulsion syndrome. There is sudden ingress of fluid which deepens the anterior chamber and pushes the iris back against the lens, and there is a reverse pupillary block, and sudden deepening produces pain, which is common in myopic eyes also, even without vitrectomy, because of the collapsibility of the globe, lower scleral rigidity. So lower the pressure or bottle height before entry of the phaco tip, and slow increase in pressure and lifting up of the iris as suggested by Sioni can be prophylactic and therapeutic. You can see there is an iris diaphragm retropulsion. As soon as you enter and the fluid is there, the iris pupil dilates so much so that you cannot even see the iris, and there is sudden pain also. So it can be prevented by setting a low ramp of IOP in active fluidics as in Centurion. It slows the buildup of pressure in the anterior chamber from 20 to 40 millimeters in a collapsible eye. So after entering, you can see after lifting up the iris with a spatula, then only enter with, and then fluid infusion is started only after lifting up the iris, which equalizes pressure in anterior chamber and posterior chamber. And if lens iris diaphragm retropulsion occurs, pupil becomes smaller later and the procedures can be difficult. So in nuclear disassembly, you also, when you start, use low parameters, low pressures to 30 millimeters or less, and vertical chopping is better. Use visco before phaco tip is out. You can see after the last piece of nucleus is out, keep the infusion going and push some viscoelastic so that the PC doesn't come up due to surge. And then careful cortical wash and polishing, and whenever necessary, if you feel the chamber is not forming well in a collapsible globe, put a suture also. So this case, you can see if there is lot of phacodonosis when you do rexus, you can see the whole lens is moving. Use a CTR for zonular stability to prevent IOL dislocation with the bag in future. It is reported in about 19% of cases when you don't use a CTR. And capsular hooks also helps in doing nuclear disassembly, and which helps prevention of stress on the zonules. So in a soft white cataract, AC may be due to myopia and vitrectomy, and often posterior synechiae is there. and use of viscoelastics, and never try to implant on fluid as we sometimes do after doing this nucleus delivery. I don't know whether we can take time. I will. Sometimes posterior plaques are not uncommon. We can try removal of the plaques on the table, or sometimes you can leave it alone for doing a YACAP later. And when there is an extension of PC rent, you can, and the rectus anterior capsular rectus is intact, you can do a posterior optic capture with a 3-piece lens, which should be there in every case. It can be expected, and push the optic behind the PC opening so that the IOL is stable in the anterior chamber. Okay. When you may have to use pupil expanding devices when pupil is small, and look for IOP. Post-op follow-up is important. You may need to follow them up more often than in a routine case, and often patients feel it's all done, and counseling is very important, that they should have follow-up with the retina surgeon. And these are some of the points to be remembered. With some planning, it can be a safe procedure, and a good outcome is possible. Thank you.
Thank you, madam, for that wonderful talk and amazing videos. Next, we have Dr. Divya Mohanachandran Nair. She's our chief instructor and consultant vitreoretinal surgeon at Abate Eye Hospital, Calicut. She's going to talk to us about perioperative considerations in patients with diabetic retinopathy during phacoemulsification.
Good morning all. So let us see what are the perioperative considerations that we will do in a patient with diabetic retinopathy who is planning for phacoemulsification. So cataract surgery is one of the most common surgeries done worldwide, and many of our patients are diabetic patients. So the end result of a cataract surgery for everyone should be a happy patient and an equally happy surgeon. But often this may not be possible, and sometimes we are faced with these kind of unexpected problems, and this may be due to undetected retinal pathologies or a diabetic retinopathy causing sudden worsening. So all types of progression in diabetic retinopathy after cataract surgery have been noted. There is at times development of severe proliferative diabetic retinopathy with neovascularization and end-stage glaucoma, and even CME is said to be more common in after cataract surgery in diabetic patients. So the pathology behind this is postulated to be that there is breakdown of the blood-retinal barrier, the blood-aqueous barrier, leading to release of inflammatory cytokines, and of course the most important molecule, VEGF. So ocular VEGF levels have been reported to peak immediately post-op on the day 1, and it settles down only after 1 month. So how can a cataract surgeon shield themselves is to do a good and thorough meticulous preoperative evaluation and determine that cataract is the only thing that is affecting the vision. So to do a good evaluation, start from the iris, look for rubeosus iris, dilate and see the whole fundus, and especially the nasal retina, because sometimes the posterior pole might look very normal and innocuous, whereas an NVE might be hiding in the nasal retina. And in a diabetic patient, it is always better to do an SD-OCT macula. Many hidden macular pathologies can be detected, and especially if you're planning for a high-end IOL like a toric IOL or a multifocal IOL. And after that, give a good counseling to the patient, let him have realistic expectations and how much retinal follow-up he needs after his cataract procedure also. So when a patient has diabetes and cataract, there are following 4 scenarios that can happen. There is diabetes but no retinopathy. There is diabetic retinopathy but no macular edema. There is diabetic retinopathy with macular edema, or there is advanced diabetic retinopathy with vitreous hemorrhage or TRD. So the dictum here is try to stabilize the diabetic retinopathy before planning cataract surgery. So when there is diabetes but no retinopathy, even when there is no retinopathy after cataract surgery, progression has been noted. So here it is very important to follow up and dilate and see the fundus after 3 months or 6 months when the patient comes for follow-up, even though he may be having 6/6 vision. So there might be a diabetic retinopathy progression happening. And of course, when there is macular edema with diabetic retinopathy, diabetic macular edema worsens post-operatively, and the risk of post-operative progression is more if there is more manipulation, vitreous loss, or inflammation. So this is just an example of a patient who had come to us and was posted for cataract surgery elsewhere. In the left eye, as we can see, there are few hard exudate lesions close to the fovea, and SDOCT clearly tells us that there is intraretinal edema, there is a small PED and some subretinal fluid. Even though it is not clear, we have enough clue to counsel and tell the patient what is going to happen post-operatively. So this is another patient, both eyes pseudophakic and has developed diabetic macular edema, and the left eye is a recent post-op where there is severe diabetic macular edema. So in a patient with cataract and diabetic macular edema, we have the following options. We either stabilize the DME with injection before the surgery, or do a combination with phacoemulsification and intravitreal injection, or a focal laser preoperatively when the edema is not center involving. So regarding intravitreal injections, we have good enough evidence back knowledge and multiple molecules available with us. There are multiple anti-VEGFs and biosimilars available. There are steroid like the DEX implant, that is Ozurdex and IVTA. There are multiple studies which compare phacoemulsification with each of the individual anti-VEGF agents. However, there is a one meta-analysis which has compared intravitreal dexamethasone implant versus anti-VEGF in a combined surgery with cataract surgery. And this meta-analysis states that in intravitreal dexamethasone implant in combination with cataract surgery provides better anatomical outcomes over a 3-month period compared to anti-VEGF. However, in anatomical terms or in functional terms, both have had equal efficacy. So, and one more thing to keep in mind when implanting a DEX implant in combined cases is, if the posterior capsule is compromised, there is chances of migration of the DEX implant into the anterior segment, and then it has to be removed. So, you can give anti-VEGF or steroid. If you are giving anti-VEGF, we have to explain to the patient that he requires further follow-up, multiple anti-VEGF injections even after the cataract surgery is needed. Though the DEX implant may have to be repeated after 4 months. And ideally, it is to be done at the end of the phaco surgery after all the viscoelastic and everything is washed out in the infratemporal quadrant. And if you're doubtful for having any wound leaks, you can ask the surgeon to just suture the wound for you. So when there is diabetic retinopathy alone without macular edema, better document and send for a post-op retina review without fail. When there is proliferative diabetic retinopathy, document and inform the patient, take a fundus photo, and if there are severe fibrous proliferation, better take an OCT to see that the macula is okay. And do a pre-op PRP whenever possible. However, at times when the lens is with severe cataractus, we may not be able to do PRP. In such a situation, do the cataract surgery and do an indirect PRP laser immediately after cataract surgery within 1 week. And sometimes we can add an anti-VEGF along with the phaco and buy time before doing the PRP. If there is severe diabetic retinopathy with subhyaloid hemorrhage and traction and all, then it is also prudent to do a combined phaco with vitrectomy, and this prevents the patient from coming again for a immediate second surgery. And if in a very dense cataract the fundus is not visible, then try to take clues from the other eye. If there is PDR in the other eye, of course there will be some kind of diabetic retinopathy in this eye, and always do a B-scan ultrasound before taking up for a mature cataract. At times, diabetic retinopathy can be complicated with neovascularization in the iris or an NVG. In such a situation, do a prompt and aggressive PRP along with anti-VEGF, and the NVI has to be regressed before planning for cataract surgery. The eye has to be quiet before planning cataract surgery. If it is intractable glaucoma, then you may have to combine the phaco with a vitrectomy in case the fundus is not at all visible, and endo laser may have to be given. Or if it is totally bad and there are mature fibrosed vessels in the angle, we may have to combine it with an endoscopic diode photocoagulation. So regarding the type of IOLs in this patient, avoid silicone IOLs because future he may need silicone oil placement, and better to do a hydrophobic, hydrophilic, acrylic IOLs, and monofocal IOL is recommended. So always remember to have teamwork with a retina colleague, and remember it is the patient's problem if we diagnose it before surgery, but if we diagnose it after surgery, then it becomes our problem. So careful preoperative planning, patient counseling, systemic control of the diabetes and hypertension, and close post-operative supervision. These diabetic patients with cataract surgery can have excellent vision. Thank you.
Thank you, Dr. Divya, for that excellent talk.
I now invite Dr. Ghana Ajoy for her talk on phaco in patients with vitreoretinal interface abnormalities. Will a combined surgery be better? Dr. Ghana is a consultant vitreoretinal surgeon at Dr. Rani Menon's Eye Center.
Thank you, Dr. Divya. And thank you, KSOS, for giving me this opportunity. My topic today is phacoemulsification in interface disorders, a retina perspective. So we all know vitreoretinal interface means it's a meeting plane of posterior vitreous cortex and the inner surface of the internal limiting membrane. And as soon as OCT became available, we were able to easily identify this interface and its important role in the pathogenesis of numerous conditions, retinal conditions. And what are they? They include vitreomacular traction, full thickness macular hole, lamellar macular hole, and epiretinal membranes. So the International Vitreomacular Traction Study Group, they developed an OCT-based anatomical classification for VMI. And they include vitreomacular adhesion, VMT, and full thickness macular hole. And these are the various, so the first one is a vitreomacular adhesion, a focal traction, a broad-based vitreomacular traction, and macular hole. So the question today is, phaco-vitrectomy, that is, do we combine phacoemulsification and a pars plana vitrectomy in one sitting, or do we go for a sequential surgery? That is, do we do it before, or do we do it after the vitrectomy? This is our question. So the first combined emulsification with PPV was done in 1990, and the indications that we know, the clear indication is, if there is a significant cataract that deters PPV, that would be the real indication for going ahead with a combined surgery. Now, if it's a clear lens, you need not go ahead with the surgery, isn't it? There is no pathology, why go ahead? It was in 1997 that they said that you can do these two together and you will have a successful anatomical outcome and a marked improvement in visual acuity. So when we do a combined surgery, what are the advantages over a sequential procedure? So we have a shorter post-operative recovery time. We have a better visualization during vitrectomy, especially towards base dissection. There is a faster rehabilitation to the best final visual acuity. And of course, patient convenience, lesser cost, fewer surgeries, far more convenient. But when we look at the disadvantages, you have intra-op and post-operative problems that we face. So when we look at it, this is a straightforward small incision cataract surgery, and a long wound has been placed. And just to show that as we deliver the nucleus, the pupil becomes really small. So this again deals with how can we proceed with the surgery. It interferes with our visualization as well. So placing the intraocular, there is just one more thing that I want to note. The wound, as the wound is very stable, and after placing the intraocular lens, the pupil size has become even more smaller, isn't it? Now, placing the entries, the wound hasn't moved at all. There is no leak from the primary wound, and silicone oil removal has been done. And during this step, we need to do a lot of depression to see the rest of the retina. So this can induce even more post-operative inflammation. So in this case, there is a corneal opacity, and we end up scraping the corneal epithelium. So far more steps are needed for us to see the posterior segment in cases of combined procedures. Now, you can see in this case, almost half the cornea has been hydrated. Post phacoemulsification. So look at this step, okay? Did you see that? So the iris has prolapsed when we are placing the our trocar cannula. This is because it is in line. We have placed it at the exact site of the corneal incision as well. So trying to put it back in, look at that, it has prolapsed again. So these are problems, and we are, our visualization is getting compromised further. We have sutured up the wound. So the view has become even more difficult for us, tried scraping. But again, this is a deep corneal edema, you're not going to do anything. Look at our view, it is very, very difficult for us to proceed with the surgery. So this, just look at the wound again. There's already an iris prolapse here. And this is because the air bubble behind the IOL is pushing up the lens. So in most of these cases, the thing to do is to suture up the corneal section no matter what. So as I said, the complications include intra-op, you faced a PC rupture or IOL in sulcus. It takes longer to perform. You may require longer anesthesia. and there is an increased risk of inflammation after surgery. Now, after phacoemulsification after PPV, as madam has already described, you can have an unstable anterior chamber, there is lack of vitreous support, there is unstable zonules. So the need for multiple operations and a longer recovery time is a detriment to the patient. This provides a rationale for a combined procedure. But studies have shown that at 3 months, a meta-analysis as well, that there is no significant difference in anatomical or functional success, and efficacy and safety have been comparable with those of sequential surgery. This is one study, which is the effect of elective cataract extraction by phacoemulsification in eyes with VMT. The purpose was to evaluate the effect of cataract extraction by phacoemulsification in patients with pre-existing VMT. So one report that they found was, interestingly, that after even an uncomplicated cataract surgery, there were cases of VMT occurring within a few weeks. It resolved on its own, but the vision loss was not always reversible. They are not always symptomatic. For the symptomatic cases, a consensus has not been reached about which is the best treatment modality. So one other thing they noted was, in diabetic patients, they ended up having no vitreomacular traction release after phacoemulsification. In patients with stage 2 or stage 3 macular holes, they rarely close spontaneously. There is a natural course of progression from stage 2 to 3 or to 4. So patients in this study with stage 2 or 3 ended up having stage 4 macular hole. One thing we can say is that this just expedites the natural course of the condition. When we look at ERM, CME, or width of VMA, and the degree of nuclear sclerosis, this did not affect the chances of VMT release. However, this is a retrospective study with a very small sample size. Now, the most common complication in phakic cases is nuclear sclerosis or nuclear sclerotic cataract progression. What this means is combined group would have obviously a better result, and most patients with this cataract would lead to a cataract surgery within 2 years. Other complications are rare, but can occur, because when you have gone with a combined case, you may end up doing more dissection than is necessary and can inadvertently induce retinal breaks and retinal detachment. With current surgical practices, technical problems are rare, and the overall closure rate was not influenced by cataract extraction. So in the 90s, they said there were 3 factors that contribute to the opening of a post-surgically repaired macular hole. One was cataract surgery. But what it has recently been proved is that there is no late reopening of macular holes after cataract extraction. So if a good ILM peeling has been done, this leads to a stable macular hole closure. This was the AO's recommendation for VMT. And they didn't have anything really to say. They said if cataract is present, it is your decision. Do you want to go with a primary surgery or do you want to defer it? So to conclude, when everything goes well in a combined surgery, then that is what we want to do. Everything is done at the same sitting. But what about the second procedure? As we know, it can occur complications can occur during the second sitting as well. This is all. Vitreoretinal surgery is all about visualization. So let it not be a habit. Let us individualize this. With excellent anterior segment surgeons, we face very little problems with phaco-vitrectomy. Let's be an essentialist and just do enough and treat the main pathology. Thank you.
Thank you, ma'am, for that excellent talk. Now we move to the next talk by Dr. Prakash, sir. Sir is going to talk to us about considerations for cataract surgery in uveitis patients on immunosuppressants. Dr. Prakash is the CMO and HOD Vitreoretinal Services at Comtrust Eye Hospital, Calicut and Talasheri. Over to you, sir.
Thank you, Divya. So we all know cataract is a common complication of chronic and recurrent uveitis. Cataract can be a result of the inflammation itself, or it can be due to topical steroids or systemic steroids. Topical steroids, you should bear in mind that more than 1 drop a day is cataractogenic. And if you look at the causes for visual loss in patients with uveitis, 40% is due to cataract, and is the most common indication for surgery in uveitic patients. And if you look at the whole number of cataract surgeries happening, 1.2% is due for uveitic cataracts, and this entity is more surgically demanding and has less predictable postoperative outcome. If you look at the indications, the absolute indication is a phacoantigenic uveitis, where the lens particles itself worsen the inflammation. or it can be due to visually significant cataract in an eye with good expected visual potential and well-controlled inflammation. Both are very important. And if you have an impaired fundus assessment in a patient and you are suspecting that there is something going on in the posterior segment, some form of inflammation is going on in the posterior segment, those cases also you will have to undergo cataract surgery quite early before you have an adequate control of inflammation. And of course, when you have a combined surgery required like a retinal detachment in a uveitic patient. So if you look at the outcome, on the whole, vision of 6/12 or better is achieved in about 60 to 80% of the patients, of which if you look at the subtypes, anterior uveitis has the best outcome with 90 to 95% achieving more than 6/12, but this is, mind you, this is without JAA included in this study. And when it is posterior uveitis or panuveitis, the success rate drastically reduces to less than 60%. VKH has about 60 to 68%. And Behçet's has got the worst among the lot with about only less than 20% achieving 6/12 or better vision. So why do you require immunosuppressive in a patient with uveitis? The most common cause is an uncontrolled inflammation in spite of going maximum steroid dose. So if the patient is intolerant to steroid, then you may have to start immunosuppressives quite early. And there are certain disease entities which require long-term immunomodulation. Steroids cannot be used more than 3 months, so those cases you will have to switch the patient to immunosuppressives. And what has immunosuppressives achieved for us is what is known as zero tolerance to inflammation. So that can be achieved only with immunosuppressives. And also it has changed the outcome of cataract surgery in severe form of uveitis. JAA alone, if you look in the pre-immunosuppressive era, only 22% of the patient achieved 6/12 or better vision. And post-immunosuppressive, this has changed to almost 70%. So this is one disease entity where immunosuppressives have changed the outcome of cataract surgery drastically. So the challenges involved in doing cataract surgery before uveitis in a patient with uveitis is, of course, control of inflammation, as I told you earlier, the zero tolerance, drug dose modification, how will you modify the dose of the drug, and what is the optimal surgical procedure for a particular patient. And in cases with posterior segment pathology, whether you should do a combined vitrectomy or phacoemulsification alone followed by vitrectomy as a second procedure, and what is the best adjunct therapy, whether it is posterior subtenon, intravitreal or implants, and IOL or not, whether to use or not in especially in younger children. So coming to the disease status, it's the most important thing before you decide on cataract surgery. It can completely change the outcome of cataract surgery in uveitic patients on immunosuppressive. So ideally you require 3 months of remission before doing cataract surgery, but this is not true in case of Behçet's disease alone, because Behçet's, it is known to have the post-operative recurrence in Behçet's is significantly related to the frequency of ocular attacks in the 12 months before cataract surgery. So ideally 12 months or at least 6 months remission is required when you are planning cataract surgery in a Behçet's. And preoperative evaluations on the slit lamp, you should not ideally have even flare, but at least no cells should be there. And OCT is compulsory because your fundus view in these cases is usually limited because of posterior synechia and all other things. So OCT will bring up new things which you didn't see at all in the pre-op evaluation. So that is compulsory. And FFA and ICG in select cases, especially in those eyes where anterior segment inflammation alone does not give us a clue what is happening to the uveitic status, especially like cases like VKH. So here you always look for on angiography the hot discs, the filling defects, capillary bed inflammation, and in ICG also you can see these filling defects. If these are present, that shows there is some activity going on. You have to wait before you do cataract surgery. And UBM is very important in patients whom you suspect hypertony. So the preoperative regimen is you have to start them on intensive topical and oral steroids, and oral corticosteroids usually started 3 days prior to the surgery. The dose is 0.5 milligram per kilogram oral prednisolone. That is half the dose that we usually use on top of the immunosuppression that is happening. And once cataract surgery is over, slowly taper 5 milligram per week until 20 milligram. And after 20 milligram, taper only by 2.5 milligram per day, per week. And in 1 or 2 weeks you can, depending on the activity that is happening. And flare can be used as a good biomarker to monitor activity of uveitis. Sometimes you may be forced to do a cataract surgery in an active uveitis. This happens when the lens becomes suddenly intumescent and AC shallows. Those cases you have to give intravenous steroids, either methylprednisolone or dexamethasone before taking up for cataract surgery. And nowadays more and more we are using preoperative or intraoperative adjunct local therapy like intravitreal triamcinolone and Ozurdex, and studies have shown that this is equally efficacious as giving oral steroids. This can be done either preoperatively 1 or 2 weeks before surgery or intraoperatively. both it has got good efficacy. And intraoperative challenges include small pupil, which can be managed with the various techniques. Pupillary membranes can be there. BSK is a common issue. If it is very bad, you can do an EDT chelation before taking up for surgery. Peripheral anterior synechiae and posterior synechiae, and always release the peripheral anterior synechiae before you release posterior synechiae. In case of uveitic cataract, you can use an viscoelastic device and swipe, push and swipe along the angle to release the posterior synechiae, then only release the peripheral anterior synechiae. Choosing the IOL, usually prefer the hydrophobic IOLs, foldable IOLs and clear corneal sections, and adjunct intracameral dexamethasone or Ozurdex or intratricot can be given in these patients to prevent recurrence of uveitis. And when to combine with vitrectomy, one indication is when you have dense vitreous membranes which going to prevent your postoperative visual recovery. Also, vitreomacular interface disorders are very common in uveitic patients like VMT, ERM, macular holes. Those cases definitely will require a combined surgery. And cyclitic membrane on UBM, if it is present, always do surgery combined with vitrectomy, otherwise you are going to end up with hypertony. And uncontrolled inflammation, especially in case of pars planitis, you can combine with vitrectomy to achieve better inflammation. And in cases where you suspect going to have hypertony or preoperative hypertony is there, you can combine with vitrectomy and put silicone oil. So what is the risk of hypertony in a patient undergoing cataract surgery? If the IOP, pre-op IOP is below 8 mm mercury, always think of possibility. Seclusio pupillae with a normal IOP, that's also high risk. And if you have an apparent phacodonosis without evidence on analysis, and on B-scan is always important in these cases. Diffusely thickened choroid or choroidal effusion if you see on B-scan, then always you can predict the possibility of hypertony. So just this is a case example where you have a vitreomacular interface disorder, that's a vitreomacular traction and an epiretinal membrane. Also there is a disc traction on a patient lady with panuveitis. And you can see that this lady has undergone TRAB also before, and we have done a clear corneal, avoiding the bleb, a section was made. Sorry. Yeah. So this is a very small pupil, so there is a pupillary membrane. The membrane is cut with the cystitome and then removed with our retinal forceps. And peripheral anterior synechiae, you have to completely go under the iris and release it completely. And any pupillary expanding device can be used in these cases, but here I am using a B-hex ring. This is quite very found to be very useful in these cases. And it's the rexis, when you do, it has to be at least minimum 5 mm, not less than that, because capsular phimosis is a big complication after uveitic cataract surgeries. So phacoemulsification is performed, and the post cortical wash and visco wash has to be meticulous. You don't want to have any retained cortical matter. This will again trigger inflammation. And then foldable hydrophobic intraocular lens is preferable in these cases. I have removed the ring. The ring can be kept till the end of vitrectomy surgery also, but I had removed it in this case. If I have to use a tamponading agent, there is a risk of it coming into the AC, so I had removed it because there was sufficient pupillary dilatation. The 25 gauge vitrectomy was done, and you can see the detached hyaloid, which was trimmed all around the fovea, leaving the foveal portion attached, because pulling that directly might result in causing a iatrogenic macular hole. So it is peeled along with the ILM and along with the internal limiting membrane after staining with BBG. So that reduces the risk of creating a macular hole. So the postoperative complications, the biggest postoperative complication is uncontrolled inflammation and cystoid macular edema. Cystoid macular edema is you will have to hike your topical steroids as well as the systemic steroids. Exudative RD is a very common complication in this case of severe uveitis. Again, you will have to hike steroids or you will have to give IV methylprednisolone in these cases. Epiretinal membrane raised IOP as well as decreased IOP is a complication. PCO is very common. Pupillary membranes will happen. There will be pigment deposition as well as giant cell deposition on the surface of IOL. This can be removed by doing an YAG polishing of the anterior surface of IOL without causing pitting. Capsular phimosis is a common complication, and optic capture as well as subluxation of IOL can have. And pediatric eye in uveitis is a big challenge by itself. JAA is the most common complication where most common scenario where you will have immunosuppressive in a pediatric eye. Here there is relentless inflammation in the postoperative period in most of these cases. PCA, Seneca, pupillary membranes, optic capture, all these are very common. And it's important that you do a primary posterior capsular rhexis along with anterior vitrectomy. You can use a tricot which will help you visualize the vitreous better. Also, it will give some amount of perioperative inflammatory control. In all children below 8 years, it has to be done. And suture all wounds. Don't leave any of the ports or main wound open in pediatric eyes. And IOL, most of the people believe it is better to avoid below 2 years. And always you can give the results of giving intravitreal tricot or as well as Osidex is very promising in pediatric eyes. So to conclude, in this form of severe uveitis on immunosuppression before planning cataract surgery, the most important thing is you should have a good control of inflammation or anticipate all these postoperative complications, and managing this well will give you usually a good visual outcome. Never deny cataract surgery in a uveitic patient because it can make a lot of life easier for these patients. Thank you.
Thank you, sir, for that excellent and wonderful talk. All the questions we came prepared for have already been answered. So now I welcome Dr. Rajesh, sir, to talk on his topic on subluxated cataract, when to approach from the posterior segment. Dr. Rajesh P. is a CMO and head of vitreoretinal services at Abate Eye Hospital, Perindalmanna and Calicut.
Thank you, Divya, for this opportunity. So I'll be talking on when should a posterior segment surgeon or when should a subluxated lens or luxated lens be approached from the posterior segment. I would say this question actually requires only answer in a single sentence because I feel that cataract surgery or cataract surgeons are very skilled these days. They have a lot of tools in the armamentarium with which they can deal with most of the subluxated cataracts. That most of the time the retina surgeon's role is mainly in dealing with a very frankly dislocated lens into the vitreous, which is lying within the vitreous cavity or lying over the retina. So most of the time it can be managed by a cataract surgeon, or when the cataract surgeon cannot do it, that could be maybe the situation where a posterior segment surgeon has to do a surgery from the posterior aspect. So just to define what is subluxation, we know that it is where the part of the lens is still within the hyaloid fossa. It's not completely displaced from the hyaloid fossa, but when it is completely outside the hyaloid fossa, whether it is in the AC or in the vitreous or over the retina, then it is called a dislocated lens. So there are various causes for subluxation. The most important cause that we commonly come across is the pseudoexfoliation syndrome. Then patients with mature cataracts and high myopia. These are probably the three situations where the zonules can progressively become weaker over a period of time. So these are conditions with progressive zonulopathy, and these conditions you can have a subluxation even after the cataract surgery. Even after a successful cataract surgery, these patients can end up with a subluxated IOL. Then patients who have undergone a prior surgery, especially a vitrectomy surgery, there can be one cause for subluxation, and a very important cause that we commonly see is the trauma. Then, as Prakash mentioned, it could be in uveitis. Then congenital conditions like Marfan syndrome, homocystinuria are all other situations where we see subluxation. So as a part of this presentation, I was very fortunate to see some of the very good videos from the anti-segment surgeons, and thank you, Divya, for the opportunity, because I saw some very good videos about how all these intracapsular devices are used by the anti-segment surgeons. And my idea of subluxation was only confined to capsular tension ring. Now I know that they have got more things like a capsular tension segments as well as sutured capsular tension rings which can deal with these conditions. So ideally a capsular tension ring or a standard capsular tension ring, that is the one that is most commonly used by most of the cataract surgeons, and this helps when the subluxation is limited to around 4 hours or a 180 degree. When it is beyond 4 hours or 180 degree, a standard capsular tension ring may not serve the purpose. And again, if the patient has got an anterior or posterior capsular tear, if you are going to use a standard capsular tension ring, then there's a chance that the tear can get extended, and that can lead to dislocation of the IOL or the lens. So if the patient has an anterior capsular tear, or the patient is having progressive sonulopathy, as in pseudoexfoliation syndrome, you should not be limiting it to a CTR alone. We should be trying for a modified CTR which have got eyelets, which can be which can be sutured to the sclera and can keep the lens in place. So what are the indications for posterior segment approach? As I mentioned, is subluxation more than 180 degree or anterior or posterior capsular tear, where the surgeon is not, the cataract surgeon is not confident enough to use a capsular tension segment or capsular modified CTR like a Sioni ring, which can be sutured to the sclera. That is probably one indication where the cataract has to be approached from the posterior segment. And another important thing is that even when the zonular support is not adequate, as I said in pseudoexfoliation, the problem is that the patients come back after some time with a dislocated IOL CTR complex. So that even makes the surgery difficult for the posterior segment surgeon, because it's not just removal of the IOL, and we also have to do extra manipulation to remove the CTR. And sometimes this can lead to more complications at the time of the vitrectomy surgery. So whenever you anticipate that there is a chance for future dislocation of the IOL CTR complex, always make sure that it is better dealt with by a posterior segment approach right from the beginning. In traumatic sonular dialysis, maybe that is one situation where the CTR is going to be very helpful, because in trauma most of the time the sonular dialysis does not progress. It is a one-time insult, and so that is probably one situation where a CTR is going to be helpful. But at the same time, we should understand that trauma can be associated with many posterior segment pathologies. So if the patient has got a subluxated lens, there is dense vitreous hemorrhage, not sure about the actual status of the retina, he could be having an underlying conditions like a retinal tear, dialysis or detachment, and especially when the posterior capsule is ruptured and there is dislocation of the lens matter into the vitreous cavity. These are situations where it has to be dealt with by the posterior segment surgeon. Then probably there is another situation where the lens is subluxated, it is dislocated or subluxated anteriorly, so that the entire the lens iris diaphragm is pushed forward. There is hardly any space in the anterior chamber. Already there is a lens corneal adhesion or peripheral iris corneal adhesion, where it is difficult to manipulate from the anterior segment. That could be another situation where you can manage it from the posterior segment. Then vitrectomized eye with subluxation. I saw Dr. Laila Mohan madam showing some very good surgeries in vitrectomized eyes. Then there is always a chance for subluxation or dislocation of the lens at the time of surgery in patients who have already undergone vitrectomy, because the cushion that is offered by the vitreous is not there. Another thing is that most of the time, whenever there is a lens touch, you can see those the mark corresponding lens touch when you examine the patient, especially in the immediate postoperative period. But after some time, when it has progressed into a mature cataract, you may miss that. So if the lens touch is the cause for the cataract, then at the secondary to vitrectomy, in secondary vitrectomy, you should always think and anticipate a positive dislocation of the lens at the time of hydrodissection. So what are the cares, the precautions to be taken by the anterior segment surgeon when dealing with the subluxated cataract? Most of the cataract surgeons, they will not do all these things, but still someone who is starting the surgery can end up with complications like engaging vitreous in the phacophobia. So you have, whenever there is subluxation, there will be some vitreous in the anterior chamber. So if it is not properly dealt with, it can get into the phacoprobe, and pulling on the vitreous in the anterior chamber can cause peripheral retinal tears. So another thing that we often see is that whenever the lens gets subluxated or dislocated, sometimes the surgeon panics. He tries to retrieve it with all the maneuvers that is available, and then the patient ends up with a corneal edema or a striate keratopathy. If that patient is managed on the same day, then maybe we may be able to do a lensectomy and take out the lens on the same day itself. But sometimes these patients are referred from the by the cataract surgeon to the retina surgeon, and the patient may be told that, see, I have talked to the retina surgeon, the surgery will be done tomorrow itself. But when the patient reaches your OP, the retina surgeon's OP, he finds that the cornea is totally white and it is practically impossible to do any surgery that day. So whenever there is a dislocation of the lens, always make sure that you do not do anything that is not in your hands. Just leave it as such, suture the wound if possible, and maybe give the patients anti-glaucoma medications and also start the patient on systemic steroids. All these will help to have a clear cornea the next day so that the job becomes easy for the retina surgeon. Then Marfan syndrome and homocystinuria, these are conditions where you see subluxated lens, and they can be managed by an anti-segment surgeon. Sometimes they even put a capsular tension ring. After removal of the cataract, they put diol also. There are surgeons who do not do that. They just leave the patient aphakic. This can be done by anti-segment surgeon, but post-segment surgeon's role is also important, because most of these syndromes, they may be associated with vitreoretinopathies, and they will be having conditions like lattices, which can in course of time lead to retinal detachment. So at the time of lensectomy, if it is even not done by a retina surgeon, it is better to get a retina examined and get all those lattices lasered, because you don't have to subject that side. Most of the time, these are very small children. You don't have to subject the child to another general anesthesia for doing that procedures. So thank you.
Thank you, sir, for that wonderful talk. Now we'll go and over to the discussion.
Any questions from the audience?
As a retina surgeon, what is your preference? I didn't see you mention anything about iris claw lenses in Marfan's. So, from your part, what would you prefer? The anterior segment to do also.
See, the preference depends upon your convenience. That is one thing. But I am more comfortable with a sclerofixated lens, so I will be doing mainly sclerofixated lens. Reason why I am not using iris claw lens is because I am not used to using an iris claw lens. That is one thing. But I have also seen reports which say that iris claw lens can have future complications. You are manipulating the iris, and you can have complications of an iris injury, and many times these lenses can get dislocated into the vitreous cavity after some time because of iris chafing and all. So in my hands,
I mean your visualization of the posterior segment.
Yeah, that is one more thing that I'm, because after the surgery with a sclerofixated lens, there is hardly any difficulty in visualizing the posterior segment after surgery. Dilatation is not that difficult.
Madam, do you see a lot of intraocular pressure rise with iris claw lenses?
I routinely use a single cut vitrectomy mode at the end of the procedure for an PI. Now, we were not habitually using doing a PI initially, when we used to have not routine, but we used to have some IOP rise. But in spite of an ample anterior vitrectomy, we do see sometimes pupillary block if you don't do a PI. So now routinely I do a single cut with the vitrector. We can use do the PI.
Madam Ani here. Do you do when you do cataract itself? If you have a rent, do you do an iris claw or you wait for some time?
When a traumatic cataract comes, we usually advise them that let us, especially when there is an anterior subluxation with an ankle compromise, then we do the cataract surgery first and advise them to have a 3-month gap.
No. I said when you're doing cataract, if you have
in
to put
vitrectomized eyes.
iris claw lens, do you do it on the table then itself, or you wait for 1 month? Or
We do no.
On the
we
table.
do it on the table. Anterior vitrectomy should be complete. so that there is no vitreous remnants at the wound. Use tricot and make sure that there is no vitreous in the anterior chamber and it is well behind the posterior capsular
I think
region.
in my hands, I think after if you wait for 1 month and do later, only thing you have to tell the patient that you have not put a lens. The vitreous
Nowadays,
will come down by itself. So then
we
it's
do
easier to-
routinely iris claw as a
on the
primary
procedure.
procedure. Yes.
One quick question to sir. Sir, in planning cataract surgery for a patient with Fuchs iridocyclitis, how do you go about the pre-operative? Do you combine it with a vitrectomy always?
No, usually cataract surgery is good enough in most of the Fuchs, but there are few cases where there is a lot of vitreous condensations and vitreous is very white in those patients. Those patients, even they get 6/6 vision after cataract surgery, I've seen they are very, very symptomatic. They are always complaining. So I did few cases combined cataract surgery with vitrectomy, and those patients are really happy. But I was looking at literature, there is hardly any literature on this subject available. So I have done 3-4 cases like that. And one patient actually told he doesn't want vitrectomy, he want only cataract surgery. I told him this option, but after the cataract surgery he was unhappy. He came back and asked me to do vitrectomy. So I feel select cases there is an indication. If you feel the assess the vitreous condensations before and then do.
And how about the anterior segment? Like, if there are stellate KPs, will you go for the surgery or you'll wait for?
No, always wait for eye to be quiet. Eye
with
to be
topical.
quiet. If whatever is required for, usually for Fuchs it doesn't require much systemic treatment. So usually it is with topicals.
Fuchs is not at all uncommon, and if there is no flare, stellate doesn't completely disappear often. So I don't wait. We give a pre-op steroid injection and then go ahead with surgery and then follow up more often to see whether there is an activity. We hardly ever see. And even with some amount of vitreous floaters, we don't, the vision is not so much compromised unless they are very symptomatic with the large vitreous condensations. Visual problem is not much and it comes in the long run. But glaucoma, yes, some of the cases, so you have to follow up more often.
Okay, thank you, ma'am. So if there is no more question, we'll wind up this session. Okay, thank you, everyone. Yeah, please, we'll wait for a photograph.